Hello, everybody. My name is Dr. Rick Lehman. I'm an orthopedic surgeon in St. Louis, Missouri, and I specialize primarily in sports medicine. Of course, everybody's talking about the one topic that has basically taken over the internet and the media, which is COVID. Everybody sheltering at home and everybody kind of getting ready for the world to open up, people to get outside, get back into sports, get active, and get healthy. Tonight, we have an unbelievably astute panel. I would like everybody to introduce themselves. Jessica, tell us who you are.
Hi, I'm Jessie Byerly. I'm the Director of Clinical Education for CORA Physical Therapy.
Bryce?
Hi, I'm Bryce Hollinger. I'm the Federal Payer Compliance Manager for CORA Physical Therapy.
Robin?
Hi, I'm Robin Cornelius. I am actually the marketing rep for hospitals, cover hospitals throughout all 9 states that CORA is in.
Mr. Modi?
Hi, my name is Dhawal Modi. I'm a Senior Clinic Manager here in Ocala and the Bellevue.
Ashley from 314, say hello.
Hi, Ashley McFadden. I'm Clinic Manager at our O'Fallon, Missouri location.
So tonight we're talking about a very, very important topic, which is basically the inactivity, the sheltering in place, everybody staying home and being unable to go through their normal routines in terms of working out, conditioning, get exercise, etc. And I think we have 2 types of patients. One type of patient, or the post-COVID patient, which we've talked a little bit about, but still their inactivity level is an issue. And then the people that have just sheltered in place for the last 2 months. They're afraid to go out. They haven't really worked out. Their routines have been changed. And now all of a sudden it's time to get back into shape. So I'd like to start with Jackie. And pretty much, actually Jackie's not on, so let's start with Jessica. I'd like to start with Jessica, and I really want to know a couple things. I want to know what the symptoms of inactivity are. So how's that manifested? And how does that affect chronic disease? If people have chronic disease or maybe have gotten chronic disease from the COVID. So my question is, inactivity, the lethargy, how does that affect long-term the chronic disease and its processes?
Sure. So there's a lot of evidence that supports that people with chronic disease, if they are doing regular exercise or regular activity on a daily or weekly basis, that helps with the management of their chronic disease. So what we're seeing is people that are now inactive and not getting their recommended daily activity, the effects of their chronic disease are increasing. So some of the things that we're seeing are deconditioning or decreased strength, decreased balance, poor fitness. We can see increased pain, decreased cardiovascular endurance or cardio disturbances. If they had a previous cardiovascular disease, now they might have arrhythmias. They could see changes in their blood pressure or unmanaged blood pressure, hypertension. And so then that kind of goes into this cycle, right? So then we have this effect of now they're not feeling good, so they have this poor quality of life. They don't want to be active, so then they might exhibit some depression and decreased activity. And then we just continue that cycle where they're depressed, and so that inactivity continues, and that cycle just continues throughout.
Thank you. So Mr. Modi, in terms of basically the concept of people being inactive, they are depressed, their cardiovascular function is decreased. Tell us about the exercise program. How does the exercise program progression work? And what does someone do when they can barely walk, they can barely ride a bike, they have very low exercise tolerance? How do they progress? And how does the exercise program progress in general?
So, I mean, again, it all depends on the patient's existing cardiovascular condition or muscle strength. or their baseline functional level. So then assessment needs to be done. When it comes to after the assessment, post-assessment, a therapist would devise a plan that would be based upon patients' pulmonary endurance. So we'll have to monitor their oxygen while they are doing the exercises. So if their O2 sats are dropping while we are doing certain reps, we'll have to manage that. So number one, we have to make sure that we consistently communicate with the patient with RMAX, so repetition max, how many repetitions they can do before their O2 sats stop. So I think in the acute phase, we have to monitor their O2 sats very closely. Obviously, we'll start with their MMT or their baseline muscle strength and see if they can start with supine to sitting to standing exercises. I think that's the basic safety. We should follow somebody who has who doesn't have that great of strength and at high fall risk. We do have some of the equipments that would come in play to build their cardiovascular endurance while monitoring their heart rate or oxygen as well. But again, it's a cautious approach. Anything from monitoring their RPE to oxygen, and then building their strength and overall endurance based on their functional level. So it would go by phase one. When patient comes in phase one, that means their oxygen, they're barely maintaining their oxygen with walking between the rooms. You have to establish a patient at phase one where they could only do open chain exercises. Or in our plan, we would put down that this patient can only tolerate 10 reps of this exercise and closely monitor their functional progress in phase one. And that phase one could go up to 2 to 4 weeks. So what we would do is have a progress note done within maybe 6 sessions and monitor their progress. Do we want to move that patient to phase two, where we can add more challenges? For example, supine to sitting exercises while monitoring their oxygen and increasing their RMAX. So essentially, it would be taking an ACL, a post-ACL patient from phase one to phase two, phase three, phase four. So I would say we should have guidelines for all the therapists, what it looks like for phase one, phase two, phase three, and then phase four. And it would be totally different for COVID-19.
Great, thank you. So, Bryce, what are the goals of therapy? When does a patient or an athlete know that they're ready to go back and play golf? When do they know that they're ready to go back and play softball, etc.? And what can the athlete or the patient expect going through the therapy?
So the goal, when we're making goals for these patients, we're really looking at what's the functional level that they're at when they're coming into therapy and where do they want to be when they're leaving. And for us, we do a series or a battery of tests and examinations to see how that patient is progressing as they go along. So, if they're able to perform at a near or exact level of what that activity is that they would like to return to, they're probably ready to be done with therapy. But if they cannot perform at near or close to that activity level, then they're not ready to be done. And there's lots of different tests that we perform on these patients, including balance testing, walking tests. There's also testing, that we can do for just like cardiovascular endurance. And we would test that patient throughout their course of treatment. And so, we're starting with a baseline that's probably not very good. We're comparing that to some normative values and then looking at where we want that patient to be at the end of their therapy. And so that's really how we're judging if they're ready to be done with therapy, if they're ready to return back to those activities. And like I said, all of those goals are based off of things that they are having difficulty doing right now and they want to get back to doing. So for one patient, it may be, I need to walk up and down the steps so that I can get to my bedroom in my house. But for another patient, maybe the 30-year-old patient who did get COVID and did not do well, the goals may be very different for that patient. And they may want to get back to playing their rec sports or whatever that may be. And so having the goal set for those individualized patients is very important. And, I think of something that all of us therapists would say to those patients continually throughout therapy is, how are you feeling? Do you feel like you're getting better, getting worse, staying the same? And as a therapist, we're always changing and progressing that plan to make sure that we can achieve the patient's goals as they're going through.
Great, thank you. Ash, real quick, tell us about the length. How long is somebody going to be in therapy who has a moderate issue versus somebody who's been in the hospital 2-3 weeks? What can they expect in terms of how many times a week? And maybe lastly, how long are they going to be in therapy each day?
Okay. I think that's very much individual based. I don't necessarily think that there's a specific time frame that we can say a patient will be in therapy. It's a matter of doing all of the objective measures we talked about, like how weak are they, how poor is their balance, how bad is their endurance with our aerobic testing. And then we develop that baseline, and with the baseline, we make the recommendation. I mean, if they're having difficulties with just daily activities like getting up out of bed or getting up out of chair, they have difficulty just getting to therapy, driving. I mean, it's going to be important that we see them more frequently, and they're of course going to be in therapy, for a longer time frame. I'd say at least, 6 weeks, 2 months. I don't think we necessarily know. Every individual is going to have that baseline, and then based on their baseline, we'll make a recommendation if we're seeing them 2 or 3 times a week and for that length of period. We're just going to reevaluate them frequently and then get them back to what they enjoy most, their prior level of function.
Thank you. And Robin, kind of fill us in how CORA is going to coordinate the sheltering in place, the workout, the returning to normal health after the sheltering in place as it relates to dealing with the hospitals and the hospital environment.
One thing that I've always brought up in the hospitals too is our wellness program, and that the patients can actually come in after they're done with treatment and use our facilities, pay a monthly fee, and use them as they would before. So it's something that I really try to express to them, that especially with the elderly patients that aren't comfortable going to a gym, if they've been to CORA for treatment, it is such a great thing to have them come in for our wellness program, because they've already used all the equipment before. They know what they're doing, but they also have a physical therapist there with them if they have any problems to ask them questions. So as far as the hospital market goes, those are kind of the things that I try to let them know that we provide above and beyond what they would normally think as far as physical therapy goes.
Great. And Jessica, kind of wrap it up. Give me your thoughts, anything we missed, and what we can add to this process of rehabilitation in terms of inactivity and deconditioning.
So I think a lot of people at home are thinking that even if they don't have COVID, that they're not being affected. But the reality is a lot of people that are just sitting at home are being affected by these guidelines that are being put in place, these stay-at-home orders or the isolation orders, even in our nursing homes where they're not able to gather. And so that inactivity is really affecting Americans with this inactivity and increasing the effects of our chronic disease. What I would say is don't wait. There are options to get active. There's telehealth, there are opportunities with CORA, we have Facebook, there's exercise. And the longer you wait and the more deconditioned that you get, the longer it's going to take to do your rehab and the harder it is going to be to get back to your normal function.
That was awesome. So I think this is a good panel discussion. I think that people sheltering in place have big challenges. There's a lot of information. There's workouts on the internet. There's a lot of information. And I think you can always call CORA and request to talk to a therapist. They may be able to refer you to a physician. But I would recommend everybody using that resource in the different cities where CORA is available, because I do think we have a significant expertise as it relates to this whole process. Spent a lot of time, done a lot of research, and I think this is going to be with us for a while. So everybody, thank you very much. Everybody have a good night.
Thank you.